one, and we are live.
So, good evening, everybody. So this is our first webinar of the PG teaching course. So I will be inviting Dr. Rajagopalan, our chairman, to start the proceedings. Dr. Rajagopalan, sir.
Yeah. Good evening to all of you. It's my proud pleasure to give the welcome address for this first webinar of the India Orthopaedic PG Training Committee, Association Training Committee, with under the leadership of Dr. Ramesh. First of all, I welcome our President, India Orthopaedic Association, Dr. Ramesh Sen, who, as he said, each time I talk to him, he is in a different place. So last time when I called him for Pondicherry meet, he was actually in the air. He was coming to India from USA. I think we are all very lucky this time that we have Dr. Ramesh Sen with us to, as the leader of the team, to guide us, because he is an international faculty and he has seen more meetings, and then he'll be able to guide us. And that is something great pleasure for us. I also welcome Dr. Atul, President-elect. He said he will not be able to join in time because he got other commitments, but I'm sure he will try to join if he's free. And Dr. Naveen Thakkar, Secretary General, Indian Orthopaedic Association. Naveen is omnipotent. He's seen everywhere. Whatever meeting I call him for, everywhere he's there. And Dr. Ramchandra, I think I have not seen him so far, but I'm sure he will definitely join. So we have a fantastic four top leaders for our associations. Fantastic. No, but I think that's a good sign that we have people. It's not necessarily all of us are there, but all of us are there to discuss, because we have four top people who really can guide us and give us ideas. We sit down and discuss. I'm sure under this leadership, we'll be doing more and more meetings. To the postgraduates who are listening, after the 2 years of this COVID, if we are lucky that it doesn't trouble us anymore, then we like to have more programs where you have a physically the feel of the patient, palpation, discussion, etc. We hope to have that. And just for information, today already one PG teaching program is being going on in Patiala, from where Dr. Rajesh is now joined us. I also thank the most important person of the day, Dr. Bavin for joining us. I don't know how many of you will know, but today already he had 3 talks. So when he told me that, I was suggesting that we postpone it because he must be tired. He vehemently said, no, I have told something, then I will really do it. So, I really appreciate your commitment, Dr. Bavin, and so happy that you are joining us, and I welcome you. I welcome my team members, Dr. Rajesh and Dr. Uday. Rajesh is in Patiala. I don't know where Dr. Uday is in Vizag only. And also Dr. Ashok Sham, after a long time, now I couldn't touch him, get him at all. I think I was busy with Byrock till then. And Dr. Neeraj and Dr. Shubhamsan. And the most important, I welcome all the postgraduates and some consultants. Just for information to the president, in fact, one radiology consultant wanted to join, so I had to send him the link for joining. So I welcome all those who are listening, and we have more programs on in the line for you, and we will be communicating. And if you have any suggestions of what more we can do for you, what changes you want, please inform us at the end of the program. So with that, I welcome everyone. If I left out everyone, then I'm sorry about it, because I have not written down. This is a extempo one. And thank you all. Now I will request our president, Dr. Ramesh Sen. One thing before I tell him that, Dr. Ramesh Sen, from next meetings onwards, we will not keep the inauguration so much. It will be only a short one. We'll go into this being the first one. I really wanted it to be a little more elaborate. I request our president to give the inaugural address and also give his comments and advice. Thank you.
Good evening, everybody. Thank you, Dr. Rajagopalan, Dr. Rajesh, Dr. Uday Kumar, to have been active now in this year also. We understand we had problems initially due to the Omicron coming up, but now, as has been decided in our meeting for this year committee, we must have to move now from digital to a physical mode also. But there are many things which can be here, and I think we have the best kind of a webinar on Zoom with the best possible material and the best possible teacher available to us, because it has not to be physical. So it is a big start for all of us to start looking radiology to start with, and eventually whatever physical things are there, they will follow. So I am really thankful to Dr. Bhavin to have agreed to come over to our this association's program, our PG teaching program. And as my request is that we should be able to keep these all in records of Indian Orthopaedic Association website, because these kind of landmark lectures are likely to be very useful for the next postgraduate generations to come. So I wish best of luck for our IOA. I wish all the best for my PG committee, for all the people, and I have to thank a lot to Dr. Bhavin to have agreed to it, and I wish all the best for his best possible contribution to our IOA. Thank you, everybody.
Thank you.
Thank you, Dr. Ramesh sir, for the kind words. Now I request our Secretary General, Dr. Naveen Thakur, to share his thoughts.
Yes, yes. I will not take much time because we are waiting eagerly to listen Dr. Bavin Bhai. He is connected with Gujarat Orthopaedic Association, Ahmedabad Orthopaedic Association with various programs physically and virtually also. So we are eagerly waiting, and all the PG students are eagerly waiting to have a real cream of the radiology of the focal lesions. So I think we should start the academic program as early as possible. Please start, sir. And I wish full success to PG committee and all PG programs.
Thank you, Dr. Naveen.
I will be introducing.
Before Dr. Rajesh introduces the faculty, there's one particular this thing that Dr. Ramchada is not going to join. Okay, fine. Sorry, he's going to Dubai. Okay.
Is my slide visible?
Yeah, visible.
So it's my honor to welcome Dr. Bavin Jankaria, who, in spite of being so busy, was able to, be with us today for this webinar. So, few things about Dr. Bavin. He did his MBBS in 1987, DMRD in 1990, and MD in 1991 from Mumbai University. He did his fellowships and trainings from University of California, San Diego, 1994, Mayo Clinic, Rochester, Minnesota in 1994, and Royal Brampton Heart and Lung, London 2002. He has around 68 articles in 6 books, and he delivered around over 1,000 invited lectures. He was editor-in-chief Indian Journal of Rheumatology and Imaging from 2007 to 2012, and he was a DNB teacher from 2012 to 2012. He was past president Indian Radiology and Imaging Association in 2014 and Indian Musculoskeletal Oncological Society from 2019 to 2021. Now he is an honorary visiting consultant radiology in Tata Medical Center, Calcutta, and he is trustee Radiology Education Foundation from 1996 till date. His special interest is in chest, bone, and cardioradiology, interventional city, business of radiology, and healthcare. So, Dr. Bavin Jankaria, please.
So, I'd really like to thank Dr. Rajgopalan and Rajesh and everybody else who's involved in inviting me for this lecture. Naveen Bhai I've known now for many years, and it's really a pleasure to be associated with IOA, and I believe this is probably the first one for this particular season. So I'm honored and grateful, and I will essentially start the talk. So my screen is visible and y'all can hear me, right? Yeah. So today I'll spend about 45 odd minutes and talk about the approach to focal bone lesions and apply what I use as the rule of 8. And this is typically when I speak to the radiology residents or the orthopedic oncosurgeons and those who are subspecializing there. It's essentially about infections, but more about tumors. Now, whenever we talk about tumors, it's not as if there are too many of them. And at some point, as orthopedic surgeons, as radiologists, and people who are involved in dealing with bone and soft tissue to some extent, we should know a little bit about each of these tumors. And there's no shortcut to that. So you need to know when they occur, where they occur, what they look like. And they're just about 3 and 4, 7, 9, 12, about 15 or 16 of these benign tumors. And if you look at malignant tumors, there are really just about 5 of them. And then you have your secondary malignant tumors, that's Mets, myeloma, and lymphoma. So that's pretty much all there is to it. So when we look at focal bone lesions on radiology, our job is to identify the lesion, differentiate benign from aggressive, identify a group called the benign aggressive lesion. In that context, rule out infection or look for infection, characterize lesions based on location and matrix, biopsy those that need biopsy, and identify leave-alone lesions that don't require either biopsy or further intervention. The modalities we have for these are our plain X-rays, MRI, CT, and PET-CT. Our focus today will be predominantly plain X-rays and MRI. Plain radiographs, remember, and this is for the PGs, that you always have to have 2 X-rays in 2 planes at 90 degrees to each other. And when it comes to focal bone lesions, the joint above and below need to be included. Now, if your radiologist or the technologist or whoever you work with are not able to do this, you need to figure out a way of getting this happening in your practice, in your institution, or wherever you are. Now, when it comes to MR, and I didn't want to spend too much time on the protocol and the terminologies, etc., because that's something that you will pick up along the way. But I thought I'll just mention how and what an MR for a focal bone lesion looks like. Now, this is a patient who has an aggressive lesion. There's periosteal reaction, a wide zone of transition in the right iliac bone, a little bit of sclerosis. The patient has pain and swelling. And this is very typical of a Ewing sarcoma. And we'll come to why this is Ewing sarcoma along within the lecture. But when we do an MR, the MR encompasses multiple sequences. And the reason we do multiple sequences is because each of those sequences shows us different facets of the anatomy and the pathology. So here is a stir coronal. A stir basically implies that the fat is suppressed and the tumor appears very bright if it has a lot of water content. The T1 is where the fat appears bright, the tumor appears intermediate, and in the bone, wherever it's sclerotic, the marrow is replaced and appears dark. We have a T2 in the opposite plane. Our T2 sequence is where the fluid appears bright, but not as bright on stir, and the fat is not suppressed. And you don't need to know all of these things except to know that there are differences, and that all of these give different sets of information. Now, if you are to look at discs in the spine, or look at ACL tears in the knee, then over a period of time, you will develop a sensibility of what all these sequences can do. Suffice to say for today, these are the different sequences that we use. We have the axial. These are very important in understanding the anatomy, the relationships to the surrounding structures. Then we would also look at the whole pelvis, if it is pelvis. If you are looking at the knee, for example, then we would examine do one sequence from the iliac crest all the way down to the ankle of both limbs to look for skip lesions, right? So all that becomes important. Then we use contrast. In MR, the contrast is called gadolinium. And when we inject gadolinium, we also inject in a way that we can scan multiple times within the first 5 minutes. And that's called a dynamic scan. So it allows us to draw curves of the patterns of enhancement of these various lesions. And then you do the post-contrast images in 3 planes. And whatever doesn't enhance is necrosis, whatever enhances is tumor tissue. If it's infection, whatever doesn't enhance is necrosis or pus, and whatever enhances is the granulation tissue that picks up the contrast. Now, whenever we look at focal bone lesions, we apply multiple rules. And when you put all of these together, it basically comes to about 8 rules, and I will run through these. The first rule is that age matters. All right, so here's a 64-year-old man with thigh pain, and we see a sclerotic lesion here in the diaphysis of the middle third of the left femur. You can see a little bit of irregular, shaggy periosteal reaction as well. On the CT, we see sclerosis with irregular periosteal reaction. On the MRI, this is a T2 weighted axial. We see the same thing. And on the T1 weighted coronal, we see the lesion very well demarcated with the irregular periosteal reaction here. And the next thing I would ask you is, what do you think this is? I mean, so in your own mind's eye, just think of the various possibilities. Is this osteomyelitis, osteosarcoma, metastases, or plasmacytoma? And just think of what you might, what your answer might be. You have to remember this statement. Secondary bone tumors are more common than primary bone tumors by a factor of 100 to 500 in patients above the age of 35. What does this mean? It means that if somebody calls you on the phone and tells you that I have a 70 or a 65-year-old man with a focal lesion in the femur, what should I do, or what do you think it is? You don't even have to look at the x-rays, or you don't even have to look at the MRI. Just on the basis of this statement and the age of the patient being 65 or 70, you can tell your resident or your colleague that this is likely to be metastasis, myeloma, or lymphoma, and you will be right 90 to 95 times out of 100 without even looking at the patient, without even looking at the X-ray or the MRI. That is the power of statistics, and that is the power of age, right? The older the patient, more likely that the focal bone lesion that you're seeing is either Mets, myeloma, or lymphoma. And this patient had metastases from CA prostate. The PSA was 45, TRAS or transrectal ultrasound showed a prostatic mass. I actually biopsied the lesion because the patient said, I don't want to do any further testing. I know I have a lesion in the femur. Please go ahead and biopsy it. So we proved that on a biopsy, and then the patient was investigated. But given that now you know that the patient, that most of the times these lesions will be met by lymphoma, it is also a good idea to investigate the rest of the body, perhaps with a PET CT or some other imaging and lab tests to figure out what this might be. So remember the first rule: in any patient above the age of 35, before considering a primary bone tumor, and I gave you that list of 15 benign tumors and 5 malignant tumors, unless there are specific findings that scream out and say, no, I am a primary bone tumor, always think of Mets, myeloma, and lymphoma. The corollary to that is that now you have this 53-year-old with proximal leg pain, you have a diaphyseal lesion, there is a moderate zone of transition, irregular periosteal reaction. You know this is an aggressive lesion. Now you know the rule. So you know that this is likely to be Mets, myeloma, or lymphoma. The MR shows that there are multiple lesions. There's another lesion here. There's actually a lesion even in the femur. The marrow is diffusely involved. What would you do next? Would you biopsy or would you investigate the patient? So we actually did a PET CT in this patient, found a large thyroid mass, and we didn't then have to biopsy this lesion because now you know that it's a thyroid primary with multiple bony metastases. However, this is the only one that was symptomatic at this point in time. So once you understand this rule, and you get the fact that almost always a focal bone lesion will be Mets myeloma lymphoma, then perhaps it's a good idea to get the person investigated in more detail before we put a needle inside. The second rule is for detection. And here, essentially, if the patient has pain and swelling, you will do the X-ray first. If the X-ray is normal or indeterminate, you should have a low index of suspicion or low index of getting a low barrier, sorry, to getting an MRI done. If the index of suspicion for osteoid is high, only then is a CT scan indicated as the first modality. Otherwise, just get an MR done. And I'll give you an example. 15-year-old boy with hip pain for 18 months has been going from doctor to doctor. Everybody looks at an X-ray like this, calls it normal. Radiologists, orthopedic surgeon, pediatric orthopedic surgeons, everybody. And nobody does any imaging. Now, if you look at it closely, there's actually sclerosis in the medial femoral area in the neck, as well as in the proximal shaft. There is some remodeling of the neck. There is osteopenia in the head, and all of this was missed, which is fine. We all suffer now from hyposcalia, so that is okay. But if you find that the patient has pain and the X-ray is normal, though this is not, you must get an MRI done in today's day and age. And this is what the MR showed, because finally they got an MR done, though the X-ray was interpreted as normal. And you see this focal lesion in the neck along the medial cortex, which is very typical of an osteoid. So you see a focal lesion in the cortex, a central ossific area, lot of marrow edema and effusion. And that's how the diagnosis was finally made. You will be surprised that in our country, and this is worldwide as well, the average time that it takes to diagnose osteosarcoma in young individuals is 2 years, right? Because the patients just go from doctor to doctor until finally somebody decides to get investigations done. And that's the CT scan finally showing the cortical osteolytic lesion with cortical thickening, sclerosis, and very typical findings of an osteosarcoma. The same is for a normal X-ray. This patient has pain and swelling in the left gluteal region. Even retrospectively, I can't see anything abnormal in the left iliac bone. While the patient has an infiltrative lesion on MR, this is a contrast study. So this is necrosis, this is tumor tissue. In the pelvis, when you have an aggressive bone lesion like this, chances are that this is a Ewing sarcoma, which is what it turned out to be on biopsy. But imagine if you continue to try and treat patients without getting these investigations done, you can get into trouble, and the patient gets into trouble, because these are aggressive tumors, and the longer you wait to get a diagnosis, the more it starts spreading. Obviously, if the X-ray is funny, we will get an MR done. So luckily, there is no issue with that. But look at this, irregular periosteal reaction. You don't want to wait in such situations. And so here the MR shows a surface lesion. In fact, you can see this periosteum that is so beautifully lifted up, which means this is a subperiosteal lesion. The MRI just shows the lesion. It doesn't really tell us even whether this is benign or aggressive, but it's aggressive because you have this shaggy periosteal reaction. And so this is a surface periosteal osteosarcoma, but that's fine. That you can come to on the basis of a biopsy. But that's the second rule. If you have a normal or an indeterminate X-ray, do an MRI immediately. It makes a difference in picking up lesions. And if the patient has pain, night pains, typically 4 a.m. in the morning, responding to anti-inflammatory, especially aspirin, then you can get a CT scan without doing an MR. The third rule is that when you have unexplained marrow edema, you must insist on a CT scan being done. And I'll come to that. So here is this patient who actually presented 2 years ago with this picture. And if you look at this study, now this could either be a stir or a post-contrast. Right now it's a post-contrast, but the same appearance would be on the stir, where we see a lot of increased signal along the posterior elements. Now, when you see just ill-defined increased signal, you would say that there is marrow change or marrow edema with a little bit of soft tissue. That's where it ends. You don't know what it is. Somehow in our country, we have this attitude that if you have unexplained changes in the spine or the hip or the pelvic bones, if you don't know what it is, treat the patient for tuberculosis. So because we didn't know what this was, the patient was put on anti-TB treatment. Patient obviously did not improve, suffered for 2 years. And then at some point went back and said, hey, listen, I am not doing well. Something needs to be done. So the MR was repeated. Now, when you see unexplained marrow edema, you must always get a CT scan done. And when we did a CT scan, what did we find? We found an osteoid osteoma. So again, you see a small osteolytic lesion, a central calcific focus. This is what an osteoid osteoma looks like along the inferior articular facet, touching the superior articular facet, but it actually involves the inferior articular facet with sclerosis, and all the rest was just marrow edema. And because a CT scan was not done, this was never picked up on the MR. And this applies everywhere. In the hip, in the knee, in the ankle, in the elbow, forearm, wherever. If there is just marrow change and the radiologist says, look, I don't know what it is, there's just some kind of marrow edema, insist on getting a CT scan done, tell the radiologist that I want to see the bone, because subtle stress fractures, insufficiency fractures, osteoid osteoma, subtle cortical osteomyelitis, osteomyelitis of Gare, all of these are conditions that are better picked up on a CT scan once you also have looked at the MRI, or based on the MRI findings, the CT scan gives you an answer. So unexplained marrow edema, always get a CT scan done. So if you read on the report that there's marrow edema and the radiologist doesn't know what's going on, pick up the phone and ask them to get a CT done. The fourth rule is then when we start looking at the X-rays and the MRs to try and understand first whether the lesion is benign or aggressive. And I use the term aggressive because infections and malignant tumors can often look the same, and both are aggressive, and that is why this terminology. Now, on the X-ray, we have just two findings that we use to differentiate benign from aggressive. The first is zone of transition. The second is periosteal reaction. The zone of transition is the transition point between the lesion and the normal bone. Now, if the transition zone is sharp and very well defined, like we see here, it means that the lesion is growing very, very slowly. It has a slow biologic growth potential. And therefore, by definition, the vast majority of such lesions, or rather pretty much all of them, will be benign. And this really is an aneurysmal bone cyst because it's in the metaphysis in an immature skeleton. Now, you can have a narrow zone of transition with a sclerotic rim. And when you have a sclerotic rim, it tells you that this is definitely benign with a certainty level that is even more than just having a narrow zone of transition, because the sclerotic rim means that there is even more time for the margins to remodel with the normal bone. You may not know what this is. This is in fact an unusual tumor called a chondromyxoid fibroma because it's actually cortex based. And that's fine. You don't have to know what this is. That can be done on a biopsy because all of these lesions have to be biopsied eventually. But you know that this is a benign lesion. It has a slow biologic growth potential. And then you would know how to proceed further as far as management is concerned. On the other hand, when you can't see a zone of transition, when it's permeative, wide zone that you see here, then that's aggressive. Now, whether this is osteomyelitis, whether this is Ewing sarcoma, that then depends on other findings. Now, here you see some very irregular periosteal reaction telling you this is an infiltrative tumor, and this was Ewing sarcoma with a pathologic fracture. But that's how zone of transition works. Narrow, sharp, well-defined would be benign. Wide, aggressive, moth-eaten, permeative would be an aggressive lesion. The same holds true for periosteal reaction. If you find thick, buttressed periosteal reaction with cortical thickening, sclerotic rim here, narrow zone of transition is also there, then this is benign. Now, this is in the cortex, in the tibia, in the diaphysis. So apart from the fact that it's a benign tumor, this fits into the diagnosis or definition of osteofibrous dysplasia. On the other hand, here we see this irregular, shaggy-looking periosteal reaction in the diaphysis of a 25-year-old with some amount of sclerosis. Where is the zone of transition? There is none. The normal, abnormal bone all seems to be blending into each other, which means it's a wide zone of transition, going hand in hand with irregular periosteal reaction. Clearly, this is a malignant tumor, and this is typical of an osteosarcoma. And then, of course, you have your classic sunray appearance, which you get because of this hair-on end kind of pattern of periosteal reaction. That is your Codman triangle. That's the lifted periosteal reaction because the tumor goes under the periosteum and lifts it up. That's the Codman again. You see a lot of new bone formation. So this is an aggressive tumor because there's shaggy, irregular, hair on end, sunray appearance with a Codman triangle. So you know that you're dealing with an aggressive malignant tumor. It's in an immature skeleton. There is new bone formation, that is osteoid is being formed. So malignant osteoid containing tumor becomes an osteosarcoma. So we're adding other things as well, because I mean, it's not like you read X-rays or MRs in isolation. I mean, the rules are applied pretty much simultaneously. But currently, we're just examining two signs on X-rays, zone of transition and periosteal reaction, to differentiate benign from aggressive. Now, on MRI, the zone of transition is not applicable. So this is that same metastasis from CA prostate. On MR, the zone of transition is very sharp, but that doesn't mean anything. So you cannot apply the zone of transition sign on MR, but you can apply the periosteal reaction. So again, in your mind's eye, just look at this, right? Look at the X-ray and the MRI and ask yourselves, is this benign aggressive or benign aggressive? And I'll come to what this term means. This is very, very important to understand. This is a 9-year-old with right thigh pain. And you can see that there's very subtle periosteal reaction in October 2014. The patient's pain continued. There was some surgery done that didn't really help. The biopsy was indeterminate. And you can see that the cortical thickening has increased. But if you look at the periosteal reaction and cortical thickening here, it appears smooth, it appears very well defined, and you would actually turn around and say, this seems to be a benign kind of periosteal reaction. But there's no zone of transition. You don't really see a lesion very well. So that should tell you that something unusual is going on. Now look at the MR. I see a lesion here, and that's a little bit of marrow edema, but look at the periosteal. Irregular the periosteal reaction is. In fact, you're seeing a little bit of hair on end here. Same appearance that you would see on an X-ray or seeing on an MRI. This tells you that this is an aggressive tumor, and aggressive would perhaps in this case mean malignant. It could be infection as well. But now on the MR, you also see that the surgery was done from the marrow edema. You need to target the tumor or the central part, which we did, and it turned out to be Ewing sarcoma. The point again is that zone of transition, periosteal reaction are X-ray criteria, whereas periosteal, on MR, you only use periosteal reaction as a criterion to differentiate benign from aggressive. So that's our rule 4, and that's what we are looking at. We come to the 5th rule, and that is looking at this so-called conundrum of benign aggressive. So please look at the X-ray and MR here and decide for yourself whether this is benign aggressive or an entity called benign aggressive. So here's a 12-year-old with left hip pain. Narrow zone of transition, perhaps a little bit of a sclerotic rim. There's a beveled edge here because it's a flat bone, so you can see that. So on the X-ray, this is a benign lesion. Now, when you look at the MRI, you see the focal lesion here, but you see a lot of marrow edema adjacent to the lesion. You also see a lot of soft tissue edema adjacent to the lesion. So it looks aggressive on MR. So when you have a lesion that is benign on histology or X-ray. So clinical definition is benign on histology, but locally aggressive. The radiologic definition is benign on X-ray, narrow zone of transition, regular periosteal reaction, etc. But looks aggressive on MR, marrow edema, effusion, periosteal reaction, but without an obvious soft tissue mass. Then that's called a benign aggressive lesion. Benign on X-ray, aggressive on MR. These are all benign tumors, but they are a very small set of tumors. Osteosteoma, osteoblastoma, chondroblastoma, CMF, GCT, Langerhans cell histiocytosis, and benign tumors with fractures. So when you see something like this, it narrows down your differential and it allows you to get to the diagnosis much easier. For example, osteolytic lesion in the head of the femur. It's in the epiphysis. It has a sclerotic rim. Now, sclerotic rim means it's benign, definitely benign. There's no question. But a lot of marrow edema and effusion, right? So when you see this, you're saying, oh God, it looks aggressive on MR. Benign on X-ray, aggressive looking on MR. This, therefore, is a benign aggressive lesion. And now you know that epiphyseal lesions like this in a mature skeleton with a sclerotic rim would imply a chondroblastoma. I mean, that you have to know. That's knowledge that you have to mug up, etc. There's no shortcut to that. But you can use the rules to reach up to the fact that this is a benign on X-ray, aggressive on MR lesion. The differential diagnosis I told you is very short. And then you know that epiphyseal osteolytic lesions are most commonly chondroblastomas. So then this becomes a chondroblastoma. All right. So infection also presents in the same manner. Here is an osteolytic lesion, ill-defined sclerosis. So it's not a sharp sclerotic rim that we saw earlier. So you don't know what's going on, right? It's an osteolytic lesion, looks benign, but the patient has a lot of soft tissue here that you can see on the X-ray. And so now you would start thinking of other possibilities like infection. Also, if there's warmth, pain, swelling, you're examining the patient has fever, then all of those things will tell you also as to how clinically possible the likelihood of infection is. I mean, you don't look at the MR in isolation to the patient, do you? So as an orthopedic surgeon, you have the double benefit of not only looking at the radiology and the MR, etc., but you also have the patient in front of you. And here you can see that there is an abscess here with a lot of fluid inside, which you can then aspirate. And then it tells you that you're basically looking at infection. So this was tuberculous osteomyelitis. Now here, for example, we see a wide zone of transition. There is an osteolytic lesion. The margins are not sharp. A lot of sclerosis around. And when you see something like this, you would say, I'm dealing with an aggressive lesion. Is this aggressive in terms of infection? Is this aggressive in terms of a Ewing sarcoma or a tumor? Now, what you see here is very irregular mottled appearance. You see this marrow change on the stir image, but you also see a lot of soft tissue. And in all of these situations, you must biopsy both the soft tissue and the marrow. Do not go in and operate until you know what it is. You don't want to create a whoops lesion at all. So whether you biopsy under C-arm or your radiologist biopsies under ultrasound or CT, you need to get that done. And when we biopsied the soft tissue, it turned out to be Salmonella osteomyelitis. So it's not that you always know whether it's tumor or infection, but you know this is an aggressive lesion and you know that it requires a biopsy before you go in. Even if your radiologist writes down and says this is infection, call up the radiologist and ask, how do you know it's infection? Unless they can convince you. If they're just saying that, no, then it just looks like infection, or I think I want it to be infection for the patient, that doesn't count. So unless you have very, very specific signs, like in that ankle that I showed you, where you could see an obvious abscess, you must go and get some material out before you start actually treating the patient. All right. So rule 5, identify benign aggressive lesions, benign on X-ray, aggressive on MR. Benign on X-ray would mean narrow zone of transition, regular periosteal reaction, etc. And identify, rule out infection, because they are also what look like benign aggressive or aggressive lesions. We come to the 6th rule. Characterize lesions based on location and matrix. Now here you must know what all of these tumors do, at which age they occur, where they occur, what they look like, because that's what you are applying now as rules. So for example, epiphyseal lesions, sclerotic rim, we know now that these are chondroblastomas, and it's also dark on T2. So that's part of chondroblastoma. There's a lot of marrow edema. So you know that it's benign aggressive and it fits in. In a mature skeleton, if you see an epimetaphyseal lesion that has a narrow zone but does not have a sclerotic rim, that's important. GCTs do not have sclerotic rims. Then this is a classic appearance of a giant cell tumor, confirmed on MR, where you see this dark appearance on T2 weighted images. But even if I am 120% sure this is a giant cell tumor, please do not curate these lesions without a biopsy, because a small percentage may turn out to not be GCTs, or they may be malignant GCTs, or they may turn out to be osteosarcomas masquerading as GCTs, and you will get into serious trouble. So the rule is, if you are going to plan to operate on any of these lesions, first biopsy them, and these should not be open biopsies. They should be image-guided biopsies. Now, supposing the lesion is purely cortical and you see a sclerotic rim, so you know it's benign, but there's marrow edema, so it's benign aggressive. And this has a typical appearance of cartilage on the contrast study. So this turns out to be a chondromyxoid fibroma. Juxtacortical, we already saw this lesion earlier when I was talking about the shaggy periosteal reaction and doing an MR. And this is a surface high-grade osteosarcoma. So what I was trying to do was show you that if you have these different appearances, like a phalangeal lesion with cartilage is always an enchondroma. A tibial cortical lesion with a sclerotic rim is an osteofibrous dysplasia. A mid-diaphyseal humeral lesion in a teenager is a simple bone cyst. Then these rules work, and you need to know these rules. You also look at the matrix, the inside of the lesion. Now here you know this is an aggressive lesion, wide zone of transition. The periosteal reaction looks good on the X-ray, but on the MR is irregular. And you see a lot of new bone formation, very dark on MRI, extensively bright on the X-ray. You know that this is osteoid. So then when you see osteoid in an aggressive lesion, you can call it an osteosarcoma. I just spoke about this. Phalangeal osteolytic lesion, narrow zone of transition, benign. It has this cumulus cloud appearance. This is cartilage. And this is an appearance of cartilage you must mug up in your mind. Some images you have to mug up like that as well. So this is cartilage. So cartilage benign in a phalanx is an enchondroma. The other appearance of cartilage is rings and arcs. So you see this rings and arcs appearance here arising from the tibia, and very shaggy appearance. This is also cartilage, but shaggy appearance will tell you that this is an aggressive cartilage tumor, and the name for that is chondrosarcoma. The same thing you see here. In the diaphysis, a long lesion, endosteal scalloping. This is what cartilage looks like on MR, and on CT you actually see this cartilage just like on X-ray, that cumulus cloudy appearance here, and therefore this becomes an aggressive cartilage tumor or chondrosarcoma. Osteochondromas you've seen, you've heard of, you know what they look like. They have marrow contiguity with the parent bone. They protrude out. They have a cartilage cap, which should be less than 1 centimeter, often even 2 centimeters is okay. This is a very thin cartilage cap here, but more importantly, the marrow contiguity, right? And that allows you to make that diagnosis as well. So anything greater than 2 centimeters thick is when you start thinking of malignant transformation in an osteochondroma, like in this patient. And I showed you that X-ray earlier. This appearance tells you that it used to be an osteochondroma, but now has this shaggy appearance and has become a chondrosarcoma. Then you have the matrix, so we looked at osteoid matrix, hard new bone, bright on X-ray, dark on MR. We looked at cartilage, soft calcification like lesions on X-ray. On MR, they seem like, you know, slightly lobulated lesions, but forget the MR. Just on the X-ray, you will see that typical cartilage appearance, or you see rings and arcs. So that's how you make that out, and then apply the rules of benign versus aggressive. Look at periosteal reaction, look at zone of transition, and then you'll know if it's a benign cartilage lesion or a malignant cartilage lesion. Same thing here. Now you see cystic and ground glass areas. Let's start with this. This is ground glass, right? You see that appearance here. And if you remember glass that has been ground and where you don't see a reflection very well, that's what it looks like. Narrow zone of transition, sclerotic rim. So you know this is a benign tumor. Which benign tumor has ground glass matrix? That would be fibrous dysplasia. Osteolytic lesion, narrow zone of transition, right? So narrow zone, benign lesion in the diaphysis, and you actually see a fracture and you see a fallen fragment here, which tells you there's fluid inside. So this becomes a simple bone cyst. Let's look at the middle X-ray. Narrow zone of transition with a sclerotic rim, and there is no matrix inside. So this is some cystic kind of lesion, but it's benign. So you don't have to worry too much about it. Look at the MRIs of these patients. Bright fluid on MR, so it confirms a simple bone cyst. Dark appearance on T2, which confirms your fibrous appearance. And then you have one fluid level, because you can get these fluid levels like aneurysmal bone cyst transformation within some other tumors. Forget about that. Just fibrous dysplasia, and that's your diagnosis. And here this lesion has the same appearance as the fat in the rest of the marrow, and therefore this is actually an intraosseous lipoma. Now, if the lesions are dark on all sequences, that's fibrous. We already saw that here in fibrous dysplasia. But here is a patient who has cortical lesions, sclerotic rims, narrow zone. So you know these are benign lesions. In an immature skeleton, these are classically non-ossifying fibromas or fibrous cortical defects. Why was an MRI done? Because the child had helicopter parents. You know what helicopter parents are, hovering around their children, who wanted and who said, how can you be 100% sure on the X-ray that this is nothing to be worried about? And the child was basically playing football and fell down and had some pain. But this was then incidentally picked up. Now, in today's day and age, if the parent wants an MRI, you say, okay, get a bloody MRI done. Why are you going to argue? And then that's what it was on MR. And they were so satisfied saying, of course, we spend so much money and now we have a definitive diagnosis. So that's also something that happens. The other thing you look for is the trabeculated expansile appearance. And I'll come back to that list. This is trabeculated expansile. I'll show you all these three appearances. And when you see a trabeculated, you see this abnormal trabeculae within a lesion. These are always benign, right? Trabeculated expansile lesions are always benign. They, like you see this narrow zone of transition here, you see a narrow zone of transition here, you see a narrow zone of transition here. So it all goes hand in hand. Then when you see something like this is your list. 5 tumors: giant cell tumor, ABC, desmoplastic fibroma, osteofibrous dysplasia, and hemangiomas. If you mug this up, and then whenever you see a trabeculated expansile lesion, you say it has to be one of those 5. Now, in an immature skeleton, in the diaphysis, it will always be an aneurysmal bone cyst. In an immature skeleton, it will always be an aneurysmal bone cyst, but this turned out to be a rare metaphyseal giant cell tumor, but your diagnosis has to be ABC to begin with. And this one doesn't actually reach the articular surface, so that is something you can get with desmoplastic fibroma. I would have probably said that it's an aneurysmal bone cyst again, but anyway, you're going to biopsy it, and that is what this would turn out to be. So the 6th rule is where you have to have knowledge of what these tumors do. And that knowledge will then allow you to find out that if you find a particular tumor in a particular location, epiphyseal, metaphyseal, diaphyseal, intramedullary, juxtamedullary, cortical, intracortical, or if they have specific matrices, is it fluid, is it fibrous, is it osteoid, is it chondroid, then you put all that information together, benign versus aggressive, location, matrix. It's like mathematics and addition, subtraction. Put all of that together, you will generally come to an answer of 1 or 2 entities. Come to the 7th, second last rule, fluid levels. And this is just something to make you understand how bone tumors and focal bone lesions work. So here are fluid levels. And when you see fluid levels, in general, you would think of an aneurysmal bone cyst. If I were to ask any radiologist what this is, they would say classically, this is an aneurysmal bone cyst, right? That's the answer. But look at the X-ray. What is this? This is an osteolytic lesion, wide zone of transition with permeation, irregular shaggy periosteal reaction. This is a malignant tumor. The arrow points to osteoid or new bone formation. So this is a bone forming malignant tumor. That is an osteosarcoma. An osteosarcoma with fluid levels is called a telangiectatic osteosarcoma. This is not an aneurysmal bone cyst. And so the rule 7 is do not interpret MRI images of focal bone lesions without X-rays. Now, this is more for radiologists, but even many of the, like I mentioned the term hyposcilia. When it comes to fractures, orthopedic surgeons are amazing because you have the patient, you know where the pain and tenderness is, where the trauma is, you look at the X-ray and you can pick out your fractures, etc. very well. Outside of fractures, the rheumatologists are great at looking at X-rays when it comes to joints and arthropathies and all that. Otherwise, the ability to read X-rays is dropping because so many people believe that once you have MR, it's not important. Patients believe the same thing. Patients come to us, they'll come for opinions, they'll come for MRIs, they won't carry the X-rays, and you ask them for X-rays and they'll say, "Arey, वो तो 150 रुपए का एक्सरे है, हम 6000 का एमआरआई करा रहे हैं, आपको एक्सरे क्यों चाहिए? नहीं तो फिर ये एमआरआई का क्या मतलब है? Why is it so expensive?" All of that stupid argument. You know, sometimes you think about it, what if the X-ray machine had been invented or X-rays had been discovered after MRI? You would be doing MRs for 200 rupees and X-rays for 6,000 rupees. Everything has its own place. It's not the cost that determines the importance of that modality. And in focal bone lesions, the X-rays are equally important, if not more important than MRs when it comes to interpretation. And this is extremely important because my colleague who reported this called it an ABC. This is a real life case. And it's only when they came for an opinion or they went to the orthopedic oncosurgeon actually, and then they looked at the X-ray and said, obviously this is not an ABC and it's a telangiectatic osteosarcoma. This is an ABC. Narrow zone of transition, sclerotic rim, benign lesion with fluid levels. That is where the X-ray and the MRI are matching, and that's how you have your diagnosis. The last rule, Biopsy, 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 unless it is a classic lever-alone lesion. So this I told you is a simple bone cyst, narrow zone of transition, blah, blah, etc. This lesion had a path fracture. It's the right age, immature skeleton, diaphysis. You would think this is a simple bone cyst, but you look at the lesion, it doesn't have a narrow zone. It's kind of got a moderate zone. Look at the cortex, right? There's cortical tunneling. There is permeation. This is an irregularly permeated lesion with a moderate to wide zone of transition. This is not a simple bone cyst. And MR was also not done. And I'm telling you, see how these things become a challenge. And this was done, right? Thinking this was a simple bone cyst, though in truth, if you leave a simple bone cyst alone with a path fracture, it heals anyway. You don't necessarily have to put K wires inside. But anyway, this was done. This is what happened 3 months later. The patient lands up with a full-blown aggressive lesion with bone destruction, and this patient basically had an osteosarcoma. And we have a term for these lesions. They're called WHOOPS lesions, WHOOPS or OOPS, OOPS lesions, wherein the rules were not followed. And when the rules are not followed, you have converted a potentially treatable lesion into something that is now going to require a 4-quarter amputation. How is this even justified under any circumstances, right? So that's what happens when we don't follow the rules. So which are these leave-alone lesions, right? Where you don't have to biopsy and you don't have to do anything. Non-ossifying fibromas, osteochondromas, intraosseous lipomas in the calcaneum, these benign cartilage lesions that are picked up incidentally. So the patient comes with adhesive capsulitis, rotator cuff tear, and you pick up this, nothing further needs to be done. So you have to be very careful. The list is very small. These are your leave-alone lesions, a phalangeal enchondroma that you pick up, or a fibrous dysplasia, etc. All other lesions require an MR to be done so that you know what you're dealing with. And if you are planning to treat the patient, you must do a biopsy in advance of intervening within the patient. All right. Lastly, biopsy rules, just so that you know how biopsies are done. That's a 60-year-old with a distal femur lesion. This is what it looks like on the MR. That's very well seen here along the medial femoral condyle. That's what it looks like on the CT scan. Nothing great. You would, I don't have the X-rays, unfortunately, but on the CT, you can see that there is a narrow zone of transition, but it's not narrow everywhere. So we were looking at an aggressive lesion. The question here is, what will be your biopsy path? Red arrow, yellow arrow, or blue arrow? Let's say you were the orthopedic surgeon doing the biopsy because you don't have a radiologist to do it, or you've decided to do it under C-arm or whatever it is. What is your path? Your biopsy path, an image-guided biopsy path, will be along the line of incision of the surgery when it is done. Which means as an orthopedic surgeon, you must know how you are going to operate on this lesion before you do the biopsy, because your biopsy tract has to be excised at the time of surgery because of the chance of seeding. So as radiologists, we are very cognizant of this. And there are times when I'm not sure what the incision for surgery will be. I actually call up the orthopedic oncosurgeon and say, tell me how to biopsy. The same thing you must know as well. And in this case, this will be biopsied along with an anteromedial approach. Therefore, that has to be the path that you will use. And that's how I biopsied it as well, right? So the biopsy in all tumors, basically, benign aggressive or aggressive, is along the line of the expected surgical incision. And radiologists, we have an article that was written in 2007 that still serves its purpose. We keep it with us, and it tells us in different parts of the appendicular skeleton what the biopsy sites will be. So to summarize, above the age of 35, everything is Mets, myeloma, lymphoma, and you can blindly 95 times out of 100 make that diagnosis without looking at the X-rays or the MRs. Normal or funny X-ray in a symptomatic patient, do an MR. CT if there's a high index of suspicion for osteoarcoma. unexplained marrow edema on MR, get a CT scan done, differentiate benign versus aggressive, X-rays, periosteal reaction and zone of transition. MR, it's only periosteal reaction. Use X-rays and MR to identify this concept of benign aggressive lesions. They look benign on X-rays, but they have an aggressive appearance on MR with marrow edema, etc. And obviously, this is the time when you identify infections as well. Then characterize them, location, matrix, all of that. Never look at an MRI without X-rays. It applies to you, it applies to radiologists. And biopsy every lesion unless it's a classic leave alone lesion, and do not intervene or operate until you know what that lesion is. Otherwise, you can convert potentially treatable and salvageable lesions into non-salvageable lesions, right? So that's what we decided to do today. Thank you so much for listening to me, and have a great weekend ahead.
Thank you, Dr. Bavin. I mean, it was not a talk. It was not a lesson. It was something above all that. I can easily tell, I'm 70, almost more than 70 years and few months. This is probably the best talk I ever heard.
Yes, thank you so much.
I'm not talking about
very clear and precise.
Fantastic, sir.
Very,
it
very
was
clear.
so smooth and a lot of things. I really wish, of course, I'm going to do it. Like Dr. Ramesh said, this is going to be kept for, recorded and kept for the pages. By pages, every one of us is every word he has said is very, very important. Over to you, Rajesh.
Actually, Dr. Bavin, we wanted to have a webinar when we discussed about radiology webinar. I discussed with Dr. Rajagopal, and we should be having webinar on how to read a normal X-ray also. Some of us are not know how to read a normal X-ray.
Well, you may know, but you're younger.
Discussed, how to read a normal, shoulder X-ray, pelvic X-ray, knee X-ray. These are the things again we want from you from. Someday maybe you have to spare some time again.
I will identify speakers for you. So my father, who's 85, is still very good at these, talking about interpretation of X-rays. But there are some good radiologists who have very good talks on X-ray interpretation, and I'll introduce you to them.
We want that, definitely. We want that. Sir, any questions? Sir, any questions from the audience if they are, for PGs if they are there?
Let me see the chat box. If there's anything in the chat box, just see in the chat box.
Dr. Uday, you want to ask some question? Otherwise, I have one or two.
Yes, sir. And first of all, it was a real master class for the postgrads and DNB students, sir. Because all the time, how to read a normal X-ray, and this all something like a easy to transition to PG. But this is a mastery class for the postgraduates, because that's keeping the current concepts and the current demands from the patients also. And I have one basic question, sir. While reading the X-rays, either it is any lesions, when do you call a lesion as a cystic lesion? When do you call it a lytic lesion? When do you call it a cavity?
So,
this is a real doubt, sir. Most of the time, whenever you read an X-ray, is it dependent on the condition which you are reading, or just how do you differentiate between these? What is the demarcation between these three?
So, cystic lesions also present as osteolytic lesions. So, fundamentally, they are osteolytic lesions. And then the question you ask is this osteolytic lesion infection, tumor, something that is not relevant? Now, for example, in a 70-year-old lady with osteoarthritis, you could have a large geode where the synovium has gone into the bone and weakened it and produced a cyst/cavity, which looks like an osteolytic lesion. It will have a narrow zone of transition, but it is also communicating with the joint, because inferiorly you don't see a margin. Then you use the term geode, but in effect, it's a cavity filled with synovium, right? But if you look at, let's say, a 25-year-old who has an osteolytic lesion with a sclerotic rim without any matrix within, then you tend to say this may be cystic. And that was what we used to say in the past. But now with MR, we would know whether it's a true cyst or not. So giant cell tumors, aneurysmal bone cysts, fibrous dysplasia, simple bone cysts, all of these were clubbed into so-called cystic lesions. But the only true cystic lesion is a simple bone cyst. All the rest are actually tumors masquerading as cysts. So that has changed now. But you're right, we just use the term osteolytic broadly. That works the best.
Usually when you're teaching this undergraduates also, usually we tend to tell them that cystic are usually benign. But when you use the word lytic or something like it, something more than that, maybe inflection or maybe malignancy, without narrow zone of transition. That's
true.
Heavy. And another point, sir, just I would like to add one more thing. This I just is not a question. Actually, I want to add rule number 9. That's what. If you permit me, you can put it as 8A or 8B, sir.
Sure.
Now, all the postcards, please listen carefully. All the students attending here. We have a very, very bad habit of writing straight away MRIs, sir. Straight away CTs. Somehow, as you said, we are in the reverse path. We are tend to write X-rays first, then go to MRI, then CT as and when required. But the tendency now is everybody comes to my clinic with an MRI, where the lesion can be easily diagnosed with a plain X-ray. So rule number 8A or B or 9 is never and ever write MRI or CT without a basic X-ray, a plain X-ray. I hope you would agree with me, sir.
I agree. So what I would suggest is that now, for example, if the patient has twisted their knee, you know that the X-ray is likely to be normal, but the MR will show an ACL tear or whatever it is. But yes, you want to get the X-ray done at the same time, simply because you could have an avulsion injury of the ACL with a bone fragment.
Yes.
You could have another bone injury somewhere else. And it's just a good idea to have that done at the same time as the MR. So I completely agree with you. Every time it's a good idea to have an X-ray along with the MR or the CT. It makes life much easier. Yes.
I feel most of our reasons, of course, it's the exceptions are the infections or some malignancies, but it is most of the times we can make a diagnosis in a plain X-ray. And I think they should be able to make an X-ray diagnosis, at least some provisional diagnosis, unless you have shown some X-rays where X-ray looks very normal, but patient is symptomatic, then definitely it needs upgrading of our imaging.
Yes.
But most of the times, I think the student should learn how to read a normal X-ray first.
True.
And then upgrade their imaging. That's what my comment, sir. If there are no more questions, any questions from anyone?
I'd like to add a little bit more to what you said. I totally agree with you that a plain X-ray should be done. But after the plain X-ray, CT or MRI, when relevant, has to be done today because it gives us much more information. Sir showed fantastic cases. Showed what all you can miss by not doing it early. But second thing I want to add is about what he said about the biopsy. This is so important today because, I just give an example. We had a medical student referred about within 1 to 2 years back. Medical student referred to, I will avoid the names. I have an ortho-oncologist who does only tumors, referred to him. But he decided to, it's a young blood, half our age, he decided to do that. I should do it. He wanted straight away to go for a surgery, thinking it is a giant cell tumor. He wanted to go for sandwich thing, etc. Everybody said, no, you do biopsy, and refusing to listen. Finally, he asked me, and I usually try to avoid interfering. I said, no, you should not do with the biopsy. Biopsy turned out to be a malignancy. And unfortunately, that went into further complication and even an amputation. But this is something which each and every word he said is something very, very important because this, unfortunately, like you said, now they don't do a plain X-ray because they don't even know how much it helps. Simple, it's ignorance. So that is a very sad situation now. That is why I said this should be heard by everybody. And Dr. Bavin, to you, most of our feedback questions come later because this is an online one.
Sure.
So sometime that we actually take it up later with you to answer
No
that.
problem.
And
Happy
any
to.
other comments, Rajesh?
And Bavin sir, and one more comment from me, one more opinion. Sir, do you suggest any book for reading for this postgraduates and DNB students? Because when we were students, we used to read Jeffy and Lichtenstein and the later Hoas. I think now Ajay Puri sir has come with one book on this chomers. You suggest
I wasn't sure Ajay has written a book, but I will check it out.
Ajay Puri sir, Ajay Puri sir.
Yeah, I know
He
Ajay.
knows, everybody.
Okay, sir. So
Okay.
there are no more
Bhavin,
questions, sir.
Huh?
Dr.
Naveen,
Naveen?
Naveen,
Dr.
sir.
Naveen? No,
Hello.
not over. Dr.
Yes,
Naveen?
yes. Can I, Bhavin bhai, can I ask one question?
Yeah, please go ahead.
How much becomes the difficult? How much becomes the difficult for reporting, Bhavin bhai, for you when it is half treated, or you know the term rodate sarcoma? Many times surgeons rode the tumor, which is pathological fracture, but they see that it's a fracture only, and they do flexible nailing or nailing, and then reporting becomes difficult, or it becomes
No, so now
half-hearted treated.
Yeah,
Then it comes to you for reporting.
we've now learned how to image with metal and all of that. So we've figured out it's not easy, but now I've been doing this for 25 years. So thoda bahut I've
Yeah.
learned how to manage and do things. So, and I'm lucky to work with, Manish, Ajay, and the younger orthopedic oncosurgeons as well. So every week we have an ortho-radiopatho meet somewhere or the other. So slowly I've picked up a
Yes.
few tips and tricks. So recently, in fact, there was an ISOL's meeting where I did a lecture on imaging with implants and imaging in these kind of lesions where, intervention has been done and how do you manage. So it can be done. It's not difficult. It's not easy. You have to find every case is individualized. Yeah.
Yeah, one more question.
Yes.
Jankari sir. And
Yes.
in osteoarthritis, when you read that the pain typically read with aspirin, it still
Yes.
holds good, sir. You can
Yes,
prescribe any
yes.
other NSAIDs now.
No.
The olden days
It
textbook,
holds
as
good.
prescription is
Yeah.
the pain relieved with aspirin.
It's not just pain relieved with aspirin. It's 4 a.m. pain. So if you take the vast majority of these night pains, they will tell you they wake up between 4 and 5 in the morning. And even if they take an aspirin in advance to prevent the pain, let's say they sleep at 12 saying that I will take an aspirin so that hopefully the effect of aspirin will last. It doesn't last. They will wake up with the pain. They have to take the aspirin. Not just aspirin, diclofenac works, ibuprofen works, all of these anti-inflammatories will work. And so I do a lot of RFAs. And so when these patients come and I'm talking to them clinically, I ask them a question in terms of when is your pain the maximum? I don't ask them whether your pain is maximum at night, because I don't want them to be biased. And invariably they'll say that we are woken up at night by the pain. And if I don't have that history, then I look at the imaging 10 times more carefully, because if the clinical appearance is not classic for an osteoarthritis, before you RFA something, you need to be 120% sure that it's not something else. And especially if it's an older patient, 35, 40 years old, it can be a fracture masquerading as an osteoarthritis. It can be osteomyelitis masquerading as an osteoarthritis. So be a little careful, but the clinical picture still holds true. Absolutely.
Oh, thank you so much, sir. I think it's my
pleasure. Thank you.
Any questions?
Yes.
Any more?
No. The only comment that it was not only a PG course. It was also a consultant course.
I think so. I think consultants need it more than PGs.
Yes.
Master class for both PGs, DNB.
Can I leave my? I need to go for the dinner in the
Yes, sir. You
and thank you so much, sir, for a wonderful class.
Not at all. My
and
pleasure.
Hope to listen to you or somebody else from your side. As Rajesh Gupta requested you. Thank you so much for sparing your valuable time, sir.
Thank you. Thank you for the invitation. Thank you so much.
Thank you, Bhavin bhai. Thank you.
My
Bye.
special
Bye.
thanks also goes to our President, Sir Ramesh Sen, and Judge Secretary General Naveen Thakkar, sir, and Atul Srivastav and Ram Chandra, sir, for giving us an opportunity once again to continue in this year also as a IOA PG teaching committee. And also, I thank our my chairman, sir, Rajgopal, sir, always supporting me and giving the necessary advices. And Rajesh Gupta, sir, my senior colleague. Thank you so much, sir. And let us meet next month, I think, with some one more IOA PG teaching course. And I wish all the postgraduates all the best. And please
Yes.
follow the webinars, note down all the notes, points which has been told today. And feel free to call us. We have our committee numbers are there. Or you can call OrthoTV also, message in OrthoTV also, any doubts are there.
Also,
Thank you.
you can write to the IO office also, and
IOA office
please
also.
and please become the associate member. That is my request from the office of the IOS, sir.
Definitely, sir.
Every teacher. This is a request to every teacher that if they become the associate member, they have plethora of opportunities for fellowships and mentorships and many things they can do.
Yes,
And
now the
I would like to announce here. I would like to announce here that IOA has a very good IOA cadaveric course, and now only few 2 to 5 seats are remaining. All the PGs or fresh pass PGs can join. This is a comprehensive, very good course. 4 days, all the approaches. Those who are not gone through, or some of the consultants are also joining, that they want to learn new approaches on the cadaver, and we are having synthes for fracture fixation on the models, and fantastic faculty for 4 days comprehensive, added with the flavor of the soft skill by Dr. Ram Chadda, how to develop your practice, which is very much important for freshly passed new consultants also. Soft skills are as important as these skills. So I invite all of you, so that few seats are remaining. So just percolate this message to all the groups and everywhere, sir.
सर टक्कर सर आप एक बार भी वो पास मैसेज वो फॉरवर्ड करो हमारे ग्रुप में, ऑर्थोपेडिक सर्जन ग्रुप में आज.
I have done yesterday only, sir.
Okay, sir. Okay, sir. With all the details also, registration details also.
Yes, everything, every links and everything is there, sir.
Okay, sir.
And Dr. Ashok, can you stop the recording so that we can have a small chit chat with our PG committee?
Exactly. I'm waiting for that.
Can you stop the recording or live streaming? Yeah, Dr. Ashok, Ashok ji, Samsul ji.
Okay.
I think it is unattended now.
It is still being recorded.
It's still being recorded. It's still live.
Yeah.
Anyway, we have our there is no secret talk.
Yeah.
How was the course, Rajesh bhai, at Patiala?
This is okay, but few things has to be discussed. I already discussed with Dr. Rajgopalan.
Okay,
It was the same
fine.
course, same type of course which Dr. Rajgopalan did in Pondicherry.
Okay.
With the patient in the auditorium, classroom.
Okay.
And a demonstration. What we will be discussing more of this. I think.
Okay, fine. Fantastic.
Make it more physical.
We will be improving on this.
Yes. Innovating and doing new things and good things.
Don't worry.
And the PG committee is doing highest work. Thanks to all the PG committee
But you
members.
don't
Yes.
want a big word.
I think
We'll give you award, Rajesh bhai. It will be an appreciation award.
Yes, thank you.
let me
In
put
Amritsar, you will get the appreciation award if you continue like this.
It is already put till September. What do you want?
Yes.
All the dates
Dil
In fact,
mange more.
We are overloaded.
No, I
sir.
think I
Amritsar
feel
का dates announce करा.
I have
Amritsar still dates are not announced, sir.
I have one comment to make. I feel this is the best opportunity for the committee to improve a lot because Naveen has got fantastic contacts. He knows everybody throughout the country as far as IOA is concerned. So we'll be able to make very good use of his contacts, get good faculty, and also I think we should again use his expertise in, for example, the cadaveric course. I'm surprised Uday asked. It is there everywhere I see, everywhere I think. all the groups, etc. I think we should also spread the message about the program. And Naveen, the Patiala program was very poorly known to most of the people. So this again, like we should be spreading the
That
information.
it was their first experience, sir.
Yeah.
Every fingers are not same, sir. So
No.
we
No, it is not their fault. It's our fault. I'm saying
yeah.
we should inform everybody.
You're
So
right.
we should probably make use of your this thing because you are
Yes,
going
yes.
everywhere in a further programs. Because this
Yes.
time, frankly speaking, even I was not able to communicate to you more this time because we had delay in bringing out the brochure.
No,
Like you said,
any
this was the first time for
no,
us.
there is a burst of activities. So it is
Yeah.
very difficult to cope up with all the activities many
Exactly.
times.
So the next time, I wanted to percolate to all the postgraduates as much as possible, and have today's Dr. Bavin was really fantastic. This is what we want. We want the good academic one, which will hopefully benefit the community.
Rajeshvi, you are at Patiala in the hotel.
No, in the Jamkhana Gaon. I'm leaving for Jammu now.
You are living now. Okay, you are
Yeah,
at the
now leaving.
Gymkhana. Okay.
Yeah.
Okay.
One more thing is, sir, now the new admissions are still pending, sir, in our state. The new
Okay.
PG admissions, sir. So
Okay.
only second years are there. First years have not yet joined. Final years are appearing for exam. That's the reason why the attendance also will be thin, sir, this time.
Yes.
So,
Same problem for us. Same problem for us everywhere.
so everywhere, sir. So
It is
anyway,
everywhere.
we have given enough communication to all the
Sir,
postgrads, sir.
should I leave?
Yeah.
Yes. We
We
all are
all
living.
can leave.
We all are living, sir.
Right, sir.
Basically, driver is waiting out, so getting late
Dr.
for
Naveen
you.
is from
It
the
will take
morning.
6 hours. 6 hours to reach.
I am since the morning because I went to the mandir at 7 a.m.
Oh my
I
God.
woke up at 5 a.m.
Thank you very much. Thank you, sir. Thank you.
Thank you.
Hey, Rajesh, you will go to a lovely Jammu. Here we are roasting in fire. The temperature is 37, 38.
Now he has left, sir. Now he will not
Yeah.
listen to us, sir. So,
Listen
sir,
to
thank
us.
you, sir. Thank you, sir. I am
Naveen,
also living.
thanks a lot, Naveen. Thanks a lot
Thank
for
you,
being
sir.
with us
Thank
all
you.
the time.
Thank you, sir.
Thank you,
Thank
Dr.
you.
Uday and
Thank you.
Dr. I think Rajesh has gone. Shamsul, thank you so much.